We're at 2017 CROI, and we're here with Kimberly Smith, who is now with Vive Healthcare and is, are you the Chief Science Officer?
No, I am the...
That's John Pottage.
That's John.
Okay.
I am the head of global research and medical strategy, so I head up R&D.
R&D, right.
Yeah.
So you've got a very important position to decide, and that's what we were just talking about. How do you decide what to do and how to do it and what's most important, because there's a million things you can do. You have to choose.
Sure.
So tell us about the study you're wanting to talk about, and then we'll talk more about why the who, what, when, where, and how of it.
Sure.
Okay.
Well, maybe I can talk about sort of the overall sort of why we're doing what we're doing.
Right.
I think that, Vive, as you know, is the only company that is 100% dedicated to HIV treatment and prevention. And so we feel like the goal is to try to deliver something that's new and innovative for patients. I mean, we know where treatment is now. Treatment has gotten a lot better than what we remember as the bad old days. And so how do you continue to make improvements? And so what we've been able to do, because dolutegravir has turned out to be a pretty unique drug that's very potent, we've been able to take it from what has been the tradition of 3 drug regimens and start looking at 2 drug regimens. And why look at 2 drug regimens? Why does it make a difference? Well, what we believe is that if you can get the same viral efficacy, viral suppression with 2 drugs as you can with 3 drugs, then there's less drug exposure and potentially less long-term side effects. And so the goal is to have people do as well as they can do with as few drugs as they need. And so that's what the study that was presented today, so 2 studies, the SWORD studies, 2 identical studies. It basically took people who were suppressed on 3 or 4 drug regimen and randomized them to stay on that regimen or switch to a 2-drug regimen that was dolutegravir plus rilpivirine. And what we showed today was that in combining the 2 studies together, 95% of folks remained undetectable, whether you were on the continuous arm or on the new 2-drug regimen. And so we think this is really the first step in demonstrating that 2-drug regimens can be as effective as 3-drug regimens. And we think that that's going to lead to, again, individuals being able to be on less drugs, less long-term side effects, simpler regimens, and so that's the direction that we're moving. So this is day 1 of that, I think. This isn't the only 2-drug regimen. We're also looking at dolutegravir with lamivudine. That's also been some pilots that have shown that works. And then we're looking at our long-acting drug as a 2-drug regimen. So cabotegravir is a long-acting integrase inhibitor, and that is combined with long-acting rilpivirine. So we're doing phase 3 studies of that. And so, again, our overall philosophy is how can you achieve long-term suppression with the least number of drugs that are necessary.
Do you imagine that it's, as a hypothesis, that the reason for people breaking through on this ostensibly is whether they've been on treatment, a lot of treatment over the years, had a lot of resistance, and maybe that are not newly infected or have some sort of special virus?
Sure.
I mean, I'm just trying to figure out why would there be.
So who would be the people who it wouldn't work for, you mean?
Yeah.
Yeah, I think that's what we will be determining that over time. What we're looking at are people who haven't had any virologic failure in the past. That's what the first set of studies are looking at. But what we intend to do is also look at individuals who may have had treatment failure in the past, but who are still sensitive to the 2 drugs that we're looking at.
Right.
And then as long as that's the case, then they would be able to use that option, and we'll see if that works as effectively. And so there's studies in the future that will look at that question. And so we don't want it to just be a 2-drug regimen that's just for people who are just newly diagnosed, who have never been on treatment before, but potentially for a wide section of the population.
Because when you go on a regimen, you can be on it for forever.
You can,
really.
Right. I mean, if you don't have toxicities or side effects, if not damaging in any way, and you're able to tolerate it, sure, yeah, you can be on it for a very long time. And so the goal is to have it be something that isn't causing not only symptoms that you can feel, but also not causing kidney trouble down the road or bone trouble down the road or heart trouble down the road, and, to be able to try to be, have it be drugs that have the least amount of side effects. That's the goal.
I remember the old days when we used to talk about, we'd throw the kitchen sink. It was everything.
Yeah.
And then we had Dan Kritzkis, I think, came along and said, if you know, pick the best three and so forth. But that was before we realized we could be on a durable regimen, I think. I think those are the days.
Yeah.
Now we have durable regimens that, like we said, could last forever. So that regimen should be the least amount of stuff that you have to deal with and
That's
process
what
by
we
your
think.
body.
Yeah, try to have it be something that you can make part of your routine, but that again, it's not going to be causing some long-term problems.
Well, this is a very good approach. I appreciate you looking at that as, I know most people say, well, the companies want to sell you as many drugs as they can. Not so. I think you're really looking at how you can improve the lives of the people.
How can we improve the lives of people? I mean, that's what our company is about. That's why we exist, is to try to do something that's better. And not just do the same old thing over and over, but actually do something that's different and that's better.
Right. Well, I think, is there anything else you wanted to broach out here to us? Because Fred, you and I have talked a lot we've talked for years and years and years. I don't get the chance to talk to you about every 6 months or so.
I know, but when before I was in industry, we used to talk about HIV in women. We used to talk about HIV in people of color. We used to talk about older populations and some of the challenges that come along with HIV, and making sure that those folks are represented in the trials. And I can tell you, I've taken that philosophy from my work before into the company, and so I'm proud to say that the SWORD studies have more than 20% women enrolled in the study and more than 25% people over 50. And we did that on purpose, again, because we want the studies to represent the populations that are living with HIV and that are more likely to be underrepresented in trials. And so, we want to do it the right way.
I think you moving from Rush University and all that clinical work there to where you're at, it's like Paul Stoffels, he said, I can be a doctor, but he says, if I can run a company, that's where it's at.
Yeah.
And he did it. So it's the same thing.
I did a lot of thinking when I was making the decision about making this move, and I ultimately came to the decision it was an opportunity to help more people. And so I'm having a really good time because we're doing good things.
When we lost you from the good, but
I haven't gone anywhere. I'm still here.
But you're doing. I think, in retrospect, okay, we can say it was a good idea.
And I can tell you that I sometimes describe myself as a troublemaker. I used to be a troublemaker when I wasn't in industry. I'm still a troublemaker.
I like to be in the rooms when you fight for the positions and the work that gets.
I'm always going to be fighting for what I think is the right thing to do.
I appreciate it. Thank you very much,
It's good
Kimberly.
to see you, Fred.
Yeah, good to see you.